and grant us insight into discussions and our deliberations this evening. Help us and better our understanding so that at the end of the day, we will impact our community and our practice even better, even to the glory of your name. For we pray with thanksgiving in the mighty name of Jesus.
Amen. Thank you so much, sir. The chairman, CPAN National, in the person of Dr. Nwafor Morin, all the executive members of CPAN National, all the desk officers of the different states and specialty groups, and everyone here present, I welcome you all to today's edition of CPAN's weekly presentation. Today promises to be a very interesting one. We have a special guest in our midst. She's a highly motivated and compassionate clinical psychologist with experience in providing mental health services in diverse settings. The specialty group presenting today is the mental health / psychiatry specialty group. She is also a healthcare organization committed to promoting mental health awareness and implementing effective therapeutic interventions for individuals and groups dealing with various psychological disorders. She's a director at the Rahma Mind Wellness Home. She's a clinical psychologist at the Memorial Hospital, all in Uganda. She possesses a master's in clinical psychological counseling. She also has a Bachelor of Arts with Education in the Islamic University of Uganda. She's a certified women intervention in substance exposure specialist. She has WISE 1, 2, 3, and 4. Ladies and gentlemen, permit me to introduce our colleague, a professional par excellence in the person of Mariam Nakamanya. I hope I got the pronunciation well. Dr. Mariam, you can unmute yourself now and Dr. Mariam.
Hello, good evening to you.
Okay. Please go ahead.
Hello.
Welcome.
Oh,
You can be heard.
Thank you. Sorry, I was trying to use my laptop, but it keeps losing network, so I have to use the phone.
Can you share your slide?
I shared them with Dr. Demola.
I mean on the call, so that people can follow you.
On my phone, no. And the laptop seems to have gone off. I don't know what's wrong. The network, it has lost network.
Okay.
Just a minute.
Can Dr. Ademola be made a host? Let him share the slide.
Okay. If he's on, maybe he can share.
Dr. Chewin, I'll send it to you.
Let me try and see if I can share.
I'll send the slide.
I cannot share this. I can't share. I can't share my slide. I can't share my screen. I didn't prepare for that.
I thought you are part of. You are also a co-host.
Yes. Let me find it.
You should have.
Just give me a minute. Let me find it. I think Dr. Kamaya, you can start while I try to sort out this slide sharing so that we don't keep people waiting.
So good evening to you all.
Good evening, ma'am.
Yeah, so as earlier introduced, my name is Mariam. I'm a clinical psychologist. And I was approached by Dr. Demola to make a small presentation, and I am very, very grateful to have you all listen to me. So it's a simple topic, and basically it's about medication adherence in patients with mental illness and the role of clinical pharmacists. I was informed that this is a group of pharmacists, and yes, for us in mental health, you play a great part in the support and healing or maintenance of patients with mental illness. So the objectives of this presentation are, I expect that we can be able to understand the importance of medication adherence. Yes, please.
Magani.
Yes, please.
Dr. Nakamaya, please unmute yourself again. I had to mute everyone so that there's
Okay.
no interference.
All right.
Okay.
All right. Thank you. So, as looking at the objectives, I expect that we shall understand the importance of medication adherence in treatment of mental health patients. Also, identify common barriers to medication adherence, why patients do not adhere to their medication as given by their doctors. Then to explore the role of clinical pharmacists in promoting medication adherence. And finally, to discuss effective strategies for patient education and engagement. So we're looking at adherence. What is adherence? Adherence is the extent to which patients take medication as given to them by their doctors. And it's one of the major factors that determine the outcomes of patients with mental illness. Yeah. Why adherence? It reduces hospitalization and healthcare costs. If patients are given medication and they take it as prescribed, then they're going to be easy to maintain. Their conditions will not worsen, but they'll be a lot more stable, and therefore they'll not be having a lot of hospital visits and not also incur costs, especially for the caretakers. Adherence also enhances patients' quality of life. That is, for many mental illnesses, people become unproductive, but when they adhere to their medication, then you'll find that they're more productive, not just at home. Some of them may even be able to go ahead and go to work. It also improves treatment efficacy. We are able to see what drugs work best for which illness, and then be able to capitalize on that for all the patients that come in with that special illness. So what are the major barriers? The major issues that we have, especially in Africa, major barriers can be divided into three or four parts. That's socioeconomic barriers. That's mostly social support, stigma, high cost of medication. Then therapy-related barriers, that's the complexity of the medication. For some people, it is the number of times that they swallow it and how long they're going to swallow it. When you give medication to a patient in a mental health clinic, the first thing they'll ask you, is this medication for life? And most doctors, most psychologists, most counselors are not able to tell this patient that they're going to be on this medication for a long time. And because of that, if a patient takes the drugs for 3 months, stabilizes, then they will stop taking it because you did not open up to them. The other barrier is condition-related barriers. For example, some illnesses are so severe that patients may refuse to actually take their medications. Some of them, the symptoms are just too much. For example, many patients with schizophrenia may not be able to adhere to their medication, especially if they do not have the support that they need. You'll find them running away from home. If they don't have any caretakers, they'll not be able to remember that they have to take medication, or they'll even be resistant, even when the caretaker tries to give them that medication. Another barrier is patient-related barriers. That's cognitive impairment, stress, anxiety. I talked about it above, where cognitive impairment is basically those patients that have conditions that have impaired their thinking, so they're not able to realize that they actually have an illness. They don't have any insight at all. So therefore, they're not able to take their medication. Then for some, it's the stress and anxiety that comes with knowing that they have to take this medication every other day. Eventually, they give up on themselves, and that becomes a big problem. And lastly, the healthcare system-related barriers, that is the doctor-patient relationship. We don't have so many specialists that are working on mental health patients, and therefore, you don't find doctors building a close relationship with their patients because the numbers are overwhelming. Limited communication regarding benefits of taking medication. Like I said, most doctors will not disclose to the patient that they have to take this medication in order to be productive. Then usage instructions and side effects. Many times, we also do not disclose the side effects. And under usage instructions, we as doctors, pharmacists, psychologists, we should be able to explain to a patient, in case of a missed dose, what should they expect? What should they do? What is the way forward? In case they encounter any side effects, where do they go or what do they do? And that becomes a barrier. When a patient gets severe side effects, they just stop taking their medication. And this does not yield any results. So what is our role as clinical pharmacists? And this is where we want to emphasize. Your role is mainly to educate the patient on a number of things. And the first thing is the name and purpose of the drug. So this patient will get a prescription from the doctor. Many mental health units do not have, or hospitals will not have these drugs. So they'll write a prescription and send them to the pharmacy. Your role as a pharmacist is to explain the following things to that patient when they come. Then the first one is tell them the name and purpose of the drug. Some patients that actually have some insights will be able to tell you, no, that is not what I have been using. Or when you're trying to give them an alternative, then they'll challenge you. So you need to tell them the name. If they've been taking it before, then they'll be able to know and realize. Secondly, you should be able to educate the patient on when and how to take the medication. Don't just write on the prescription, on that envelope, and hand it to the patient. You need to be able to tell them whether before food or after food, whether in the morning, how many tablets to take in the morning, how many to take in the evening. Yeah, so that they're able to understand the medication that they're taking. Don't take it for granted. Some of them have insight, but many do not have insight. Number 3, possible side effects and precautions. Should be able to tell the patients what to expect. Yeah, some of this medication is going to really destabilize them, make them sleep a lot, make them a little stiff, all those side effects. Tell them what to expect and how to counter the side effects. Then interaction with food and other drugs. Some of this medication does not interact well with other drugs and certain foods. That role is also left to the clinical pharmacist. It would be best explained to the patient by the clinical pharmacist, because this patient is before you, and as you give the drug, tell them the name of the drug, what it is for, whether it's an antidepressant, an antipsychotic. Then you also should be able to tell them whether, there are other drugs, ask them whether there are other drugs they're taking, and then so that you can manage the interaction and reduce on whatever side effects may occur. Next is the duration of the dose. The duration of the dose, I spoke about it in the previous slide, should be able to tell them whether the doctor has prescribed for a month or 3 months. And in case it's for a month, you need to be able to tell them when you complete this dose or before you complete, go back and see your doctor for review. They should actually go and see their doctor before the drug runs out. That one, it would also be nice if it's explained by the clinical pharmacist. Then action to take if the dose is missed, and how to tell if medication is working. So sometimes because some drugs really make them sleep, they'll miss a morning dose. You should be able to explain to them, if they miss a morning dose, what is the best practice? Do they have to take it when they wake up so that they take their night dose much later? Or do they leave it and go ahead and just wait for the evening dose? And then they should be able to realize that the medication is working. Sometimes some patients take medication and it's not helping them. There's no change. So you might be of help if you explain to the patient or their caretaker what to expect after a certain period of time. They have been taking an antidepressant. You should be able to tell them that after this drug will start working after 2 weeks. And after 2 weeks, what are those things they should expect? Maybe the mood uplift, maybe a better appetite, so they should know all these things so that they are able to identify. And in case it does not work like that, you should be able to advise them to go back to their doctor so that the drug can either be changed or the dose increased. So what are those strategies that the pharmacist can use to improve the relationship with the patient? Be friendly and approachable. You enter some pharmacies with your prescription and the person does not even look up at you. They do not look up at you. They are not welcoming at all. So the patient is not even able to ask you any questions, or their caretaker, for example, will not be able to ask you any questions because you're not approachable, you're not friendly, you're not welcoming. So be friendly. Let's be friendly and approachable when we receive those people at the pharmacy. Then improve communication skills. By that we mean you have to give a clear explanation. Ask some patients in case they have insight, or their caretakers if they know what condition their patient is suffering from. Sometimes patients pick up prescriptions that are not theirs. So it would be good for you to communicate with them, ask them whether they know the condition and the drug, why they are taking the drug. They will be able to tell you, and you could save a life in case somebody picked a wrong prescription. Then improve patient education. I believe the pharmacists are in a better position to educate patients about the medical treatments, the medical therapy, how drugs interact, what doses should be able to help. Someone will come and tell you, I have been taking a high dose of CPZ, but it makes me so weak. I am so drowsy during the day. What would you advise? Sometimes this patient is very far from their doctor, but you can help them because you know how these drugs work. So you should be able to educate them and tell them, maybe take
Please unmute yourself, Mariam. We can't hear you. Please unmute.
Hello?
Okay, please continue. You can hear you now.
So I was saying, encourage the patient to discuss their main concern. Ask the patient, what is your main concern? How does this drug treat you? How do you react to it? Are you comfortable with it? Let them open up to you so that you know how to best help them. Then check patient understanding. Some of these patients actually know the drugs they are taking, why they are taking them, but they'll come and hoodwink you at some point, depending. For example, the bipolar patients, they know everything that is going on. They know why they are taking the medication, but then you need to know. Sometimes they want a change of drugs. So they'll come and tell you, no, that drug is not working for me. I think I should take this one. You need to be able to identify whether they're in their right state of mind or not before you give the prescribed drugs. Then simplify the therapy regimen. For example, if someone is going to be swallowing 4 different tablets in the morning and then swallowing just one in the night, you can simplify it for them. If you can break it down and say, instead of swallowing 5 in the morning and then 1 in the night, maybe you swallow 3 and then 3. So it becomes easier for the patient to manage, and you build a relationship with them. They'll also be, they'll adhere better to their medication when some things are done simply like that. Then listen actively and be empathetic. Try and put yourself in that person's shoes. If it were you, how would you have wanted to be spoken to? How would you have wanted to be helped? And also, when you listen actively, it means you're going to pick important information that could have been missed by the doctors, the psychiatrists, the psychologists, and you can be able to front that information so that the patient can be helped. So what are those tools? Next slide. What are those tools and resources that the pharmacist can use? 1, adherence aids. That is, recommend pill organizers, medication reminders, mobile apps. For those that tell you, me, I usually forget my morning pills, or I forget my evening pills. Some of them will not even remember how many tabs they're supposed to take in the morning or in the evening. So as a pharmacist, you can recommend, I recommend pill organizers a lot. And I have had organizations that have donated pill organizers, and I usually also donate them to those, especially the caretakers, because most caretakers are not there. They leave early in the morning, they come back in the evening past the time for the medication administration. So, but if you leave for the people at home, even if they cannot identify the drugs, you just put them in the pill organizers. The pill organizer will have morning, maybe lunch hour, and evening. Then it will be easy for the patient to be able to take their medication. Then there are also apps, mobile apps. You can encourage them to set reminders on their phones or on a clock at every given hour. They have a reminder, so the phone rings or the clock goes off, the alarm, so that they are able to remember that each time the clock goes off, the alarm goes off, it is time to take medication. 2 is education materials. Provide handouts or brochures. Most pharmacies will have a lot of brochures. Don't keep them, share them for different drugs and importance of adherence. If you have them, share them with these patients and their caregivers so that they are reminders. If someone goes with a brochure and they have one in the sitting room, one at the table somewhere, one in the corridor, then they'll be able to remember. Then implement follow-up appointments or calls to check on adherence and address any issues. Many times the follow-ups are not done, and that is our weakest link. There is no follow-up. You work on somebody, you put a lot of effort, and then when you don't follow up, usually you lose it. Some keep postponing their appointments. Oh, I'll go. But if you also help, because you know this patient is supposed to have a refill in a month's time, and then you help to follow up, that will be a wake-up call. So while they come for a refill, they'll also remember that they had a review with their psychiatrist, with their psychologist, and there we are able to work together to ensure that we give these patients better health. What are those ethical considerations as you help this patient? Yes, you're doing your role, you're trying to help, but they are ethical considerations that you need to watch out for. The first one is patient autonomy. That is, respect patients' rights to make informed decisions about their treatment. So do not tell them, your doctor, this is what your doctor prescribed, this is what you've been using. However, I want you to try this treatment. No, they should be able, in case they're in the right state of mind, they should be able to tell you what medication they are using and whether they want to continue using it, or ask their psychiatrists, their different consultants, whether it is okay to use what you're recommending. Then informed consent, ensure patients understand their treatment options. When you're giving them whichever medication based on their prescription, please ensure that they understand. If they don't, then you have to ask for a caregiver. Don't just give the medication. You have to ask for their caregiver so that they're able to support them. Then coercion, share the ethical implication of coercive treatment practices. Some pharmacies, especially if it's not within the hospital, as this patient just comes to secure the medication from their prescription, you cannot coerce them, or they cannot coerce you. Some of them, the doctor will have given a specific dose and then they want to coerce you to give them a higher dose. You should be able to tell them that is not right and it is not ethical, and explain to them the consequences that could come with that. So it can be two-way. It can be the patient or it can be the pharmacist. So in conclusion, please remember that your role in supporting medication adherence in patients with mental illness is indispensable. Pharmacists are very crucial group in helping mental health patients. And by leveraging your knowledge, communication skills, and patient-centered approach, you can significantly contribute to improving adherence rates, enhance quality of life for patients, and ultimately lead to better health outcomes. Thank you. And that is me. If there are any questions, I'll gladly take them.
Thank you so much, ma'am. Thank you for a very concise, straight to the point, and interesting presentation. We're very grateful, ma'am.
You're welcome.
Yeah. So I was able to gain a few points from today's presentation. One
Yes,
being
please.
that there are similarities between practice in Uganda and Nigeria, but it looks like the community pharmacy practice is much more pronounced and dominant than the hospital pharmacy. I don't know, I could be wrong, but that's what I perceive.
No, you're right.
Okay, so we are going to be entertaining some questions because sometimes we as pharmacists, we have gotten so used to doing our job that it looks like why are we talking about the psychology of medication adherence when it's something we do all the time? And that is why this clinical psychologist has come to throw more light into what we're doing. We would be entertaining questions. Please raise your hands. Dr. King David, the floor is yours.
Yeah, Pharmacist King David. Good evening, everyone. I want to appreciate our presenter. Sorry, I joined in late. I had some issues connecting, so I don't know what I'm about to ask if it has already been answered before I joined in. But then, as pharmacists, do we think there was this work we did last year, and I want us to some sort of um, relate it to medication adherence, either generally or in respect to mental patients. Yeah. So do we think color of drug or physical properties of drug like color, size of drug, or shape of drug has a way of affecting psychology of patients, especially narrowing it down on in this context, mental patients. Last year, Professor Bolajo Kaina and a few of us did this work on, and we found out against us, surprisingly, that sometimes color of drugs may not really affect adherence. So I want to find out if it is the same with mental patients. Are there ways we could either change the physical properties of these drugs to make them accept it more? That's just my question in a nutshell.
Thank you very much, Fan King David. I think we'll just take all the questions one by one, and then we'll answer them later. Christopher Ugu, please, the floor is yours. Unmute yourself. Unmute yourself.
Hello, good evening.
Good evening. Can hear you.
Okay, thank you. I must say, my name is Amasugu Christopher. I work with Federal Neuropsychiatry of the Yaba. I really appreciate the psychologists for coming up to level of presentation. My observation first is the level of the use of the doctor in the presentation. For us, their practice, sometimes it's mixed up the issue of doctor when you want to make mention of a psychiatrist and the issue of a pharmacist. Doctors don't give medication in a psychiatric setting where I work. The doctors prescribe. So even the first question asked, please, in terms of answering, I will like to participate to contribute to that. My own view about the presentation was very precise. But what I wanted to bring up is the level of involvement of pharmacists, especially in the issue of, I wouldn't know in Uganda, the availability of medication in their hospital setting. Though you've observed that it's like they do more of a community than the hospital setting. And there's other institutions like what I hear and observe in the other countries, like in mental health, like some hospitals, the government used to procure buy the medication in bulk to reducing costs. In Uganda, is it? In Uganda, is it the other style? Because in our own in the country, is one of the aspects, one of the things that affects medication adherence to our clients. And the issue of availability of medication in our health setting, if we can tell ourselves truths, the level of involvement of our drug recovery fund made it. I can use my institution if I have been allowed. I might give a more clear clarification. The level of availability of medication in some most mental health settings really affected the level of adherence of to medication by our clients. So I needed to know, my major question is on the issue of procurement of medication in this institution, whether it involved the government or not. Thank you.
You mean in Uganda?
In Uganda, yes. I want
okay.
In Uganda. Because I know I know our own setting already now.
Okay.
Thank you.
Dr. Suleiman, your hand is up. The floor is yours, sir.
Yes, thank you. I first of all want to thank the presenter, and I also want to make a little contribution or rather clarification. Number one, in Uganda, where I'm practicing, the practicing pharmacists are actually addressed as doctors. So you're obviously going to get confused because we wear our lab coat with your name tag as doctors because our license is written as doctors. And that is probably what you will have noticed in the presentation, because sometimes she may actually say Dr. A, but obviously probably still referring to a pharmacist because that is one of the practices. And the community practice is well entrenched here. It used to be what it used to be in Nigeria in those days, where everybody wants to go to the community. That is what it is here. It is almost everywhere, and so the patient that has the ability can easily go into any pharmacy and fill his or her drugs, as the case may be. The issue of the drugs too is also centralized. You go to the central store and make a procurement, as the case may be, depending on we call what is usually called a teaching hospital. In Nigeria, we call it a referral hospital, though it is of different category. We have a regional referral, we have a national referral, but I think it's a tertiary institution that probably a teaching hospital or tertiary institution like neuropsychiatric hospital in Yaba. So that is how the lack of neuropsychiatric hospital in Yaba is refers to as national referral hospital in a specialized area. Psychiatric will also be orthopedic, depending on the special and their specialty. So that is one thing that I want us to put in mind when you are actually making contribution or asking question. Pharmacists, doctors, psychiatric, all those things, they are actually in their practicing license. We are addressed as doctors. Thank you.
Thank you so much, sir, for the clarification. The last question that was asked by one of us here, I think it has been answered. But that question that has to do with size, color of drugs, whether it affects medication adherence in mental health or psychiatry, I don't know if there's anyone who can answer that question. From my own experience working in Federal Psychiatric Hospital, Calabar, it's as if the patients have resigned to whatever it is they've been prescribed to take. For example, trifluperazine, popularly called stelazine, is blue in color, and they take it like that. So, but I don't know if anyone else has a contrary opinion. Is it possible that the color puts them off and discourages them, therefore affecting medication adherence negatively. Pharmacist Christopher Ogu, you can unmute yourself. Your hand is up. Whether you want to
Yes,
ask a question or contribute, please go ahead, sir.
thank you. I said earlier, thank you for accepting me again. I said earlier that I like to participate because the question was asked in terms of the physical ability of the research they said they did in the Professor, you know. So I want to give an input on experience. I've been in Federal Neuropsychiatric Hospital for getting to 20 years.
Okay,
So
sir.
I must testify to you the level of involvement in medication therapy there. Dr. Ademola was once with us before he left out of the country. The level of coloration size brings about the acceptance of medication from their clients. If that research, maybe thoroughly, maybe we didn't get to our side or get information, or maybe our own was not pronounced. But as I'm working Yaba, if our client imagine to the level of benzodiazole they are using to manage the side effect of medication, there's a side, that one that has a conical flax on it. There's a bigger size and a smaller size. Then we have clients that if it's not that big size benzodiazole, they will never accept it as being 5 milligrams. Yes, they will never accept it to be benzodiazole. No, I need Athene. You're telling them that you are trying to convince them that what they are collecting is Athene, but they will reject it because it does not look like that thing he believed to be an Athene. The size has been changed. If you currently, you know, the current one you are using now is not as big as the one you use for biomedicine. The same thing, like you made mention of trifluoperazine, TFP. If the variation in blue color, the color of the blue, if it deepens the color, some clients know this color doesn't work for me. If you check in our brand of Risperidone, if those that use Risperdal with the brand of Janssen Risperdal, those that use Zepidone, that of biogenerics, you find out the color, the 2 milligram, they are pink, but their color varies. Some will insistently tell you, no, yes, this is not my medication. You are the doctor, you'll be eager to collect the prescription for you. You want to go back to the prescriber. Has it changed my medication? It's not left to our responsibility in level of adherence to tell them, do you have the old prescription you have? If you have attended it, you see, this is the same, but now you are getting a brand from a different company. There's a Risperidone now from this is the one from what do you call it? Micronova. That is even that cannot be scored, that the shape is sugar. All these things, our patients are very, very key. There's so much attached interest to the color shape of their medications. So these are very typical issues with the mental health, and is affecting their accepting medication there, and that's where most of us, our job as pharmacists, trying to explain to them, convince them, let them to believe that some will tell you this person medication, it doesn't work for me. As a brand of Risperidone and Altadone, most of them will say, no, it doesn't work for me. Yes, we will tell you when it's economically, you check the cost of that Altadone now to Risperidone, the wide gap in the price. But they will still believe that, no, even when the family members are trying to accept the one because of cost, there's the one they can afford. But the client, the patient itself, that one that's following medication. No, mommy, or client, your patient, you are trying to change my medication. What is your intention? Don't know. So let me not overstress it. Color and shapes and the physical properties of the medication in mental health is really affecting their
Very
acceptance.
important.
Yes,
you are very correct, sir.
Thank you very much.
You are very correct. Before I unmute Dr. Aloysius, I want to say something that would sound childish. We in mental health, I wonder, do we ever think whether it would be better for our patients to get these drugs free of charge or almost free of charge? Will it improve adherence to medication like they do in HIV and the rest? And if so, why hasn't the government, keyed into this to make it happen for our patients? From Aloysius, you can unmute yourself.
Okay,
The floor is yours,
thank you
sir.
very much. Thank you very much. It's actually a wonderful expose and eye-opening. However, I just have a question with respect to a follow-up with Farm that just spoke lately. I believe that what he has actually talked about also plays out in certain other areas of pharmacy practice, particularly community pharmacy, with respect to even when it comes to antihypertensives as well. For me, I actually practice within the community pharmacy sphere, and we see very few mental health cases. However, I want to believe that it's actually the pharmacodynamics, pharmacokinetics of that particular drug formulation. I believe that that is actually what is playing out here. For instance, I know that generic products with that has a longer disintegration time and that delivers the active component at a slower rate. You tend to have patients not being not doing very well on it as compared to the parent the parent substance. And so you find that when you present them with just even the packaging, and there's that difference, they just get that no, this is not my medication. I think not for anything, for the fact that they will not get the same kind of relief and the same kind of effect. So I believe probably that's just my belief that it might be coming from there, as opposed to just definitely probably you will also have maybe coloration difference with respect to what the generic has to offer and what the main principal listing has to offer. So that's actually my contribution and my question. Thank you.
Thank you so much. So, in effect, our patients in psychiatric hospitals are not necessarily peculiar in their way of accepting medication. It's cuts across all the fields of pharmacy practice: oncology, endocrinology, cardiovascular, ophthalmology. I want to ask our presenter to make comments on the questions and observations that have been made so far. Please, dear presenter, the floor is yours. Thank you, ma'am.
Thank you. I would like to say, yes, I agree. Color, size, shape of medication cuts across. It's not just for psychiatric patients. Many patients will show concern, but I've had an opportunity to be, for example, in our main psychiatric hospital. We have one major psychiatric hospital, and it's a national referral hospital. So people come from wherever in Uganda and are referred. When you fail, because at the regional level, we have the general hospitals and they just have psychiatric unit where you have one psychiatrist, maybe a psychologist, and a social worker. So when they get major cases, they refer. They have to come all the way to Kampala and bring to the National Referral Hospital. That's Butabika. So I've had an opportunity to interact with the inpatients. And in the morning, as you give out those drugs, they'll tell you, by the way, they'll tell you, no, me, I take blue and pink. And it's up to you to explain to them, that the pink is not there, but today we brought yellow to work like pink. And when you explain, as long as you explain, they'll take it. But if you just give them, they'll throw it away. So it's a concern, and that is the role of the clinical pharmacist. Now I'm talking about when they go out to the community, because the government actually provides some drugs, but not all. And then because of the numbers, they are overwhelmed. So the drugs will never be enough. So when they give you, the most they can give a patient is maybe a prescription for a month. And then they'll tell you the psychiatrist will see you in 3 months. So the other 2 months, you have to go and buy from the pharmacies in the community. So that is where I stress that when they come to you, when these patients come to you, but usually most of them come with caretakers. It's very key that we explain to the caretakers what, if in case you're changing the drug. For example, if they are 10, sometimes you have a higher milligram, so they have to break it into 2. And then they'll say, no, at 10, I take a full tablet. They don't want to take half. So the pharmacist has to explain to the patient and the caretaker why they are going to take half. And if the option is there, if you think they don't understand it, then refer them to maybe another pharmacy where they can get it in the right milligram that was prescribed for them. Then about giving drugs free of charge, it's something that we are all advocating for. It's one of those things we are advocating for, because many of those psychiatric medications are expensive, at least here in Uganda. The treatment is expensive, and many people cannot be able to afford it. So if they can at least give it for free, then we probably will have the numbers reduced, because there's a lot of relapse due to that shortage. If the medication runs out and the family does not have money to buy the medication, then of course the person is going to relapse. And many times they'll stay in their homes, in their villages, and wait for the 3-month period of review that you gave them, even when the medication has run out. So I think the government, it's one of those things that we are advocating for. These days, I don't know how it is in Nigeria, but in Uganda, there's this craze about mental health. Everyone is talking about mental health because it cuts across different levels, children, youth, adults, and we are hoping we can somehow raise our voices and they get heard, so that they can focus on bringing in that medication and to issue it out free of charge. Thank you.
Thank you so much, ma. Quite a lot of lessons to learn from Uganda. Maybe CPAN, psychiatric/mental health specialty group, will form an advocacy team to plead, to get a policy in place, to get drugs at if not free, subsidized rate for our patients, because not adhering to medication is a big part of relapsing, is a big part of our problem. Yes, ma'am. I want to recognize the presence of the chairman of CPAN, Dr. Maureen. Is she still on the call? 1-4. I also want to remind pharmacist Hanifa that she should be on standby to say the closing prayer. But before we get to that, our desk officer 1, Dr. Ademola Suleiman, you may need to say 1 or 2 things. Then our CPAN chairman will say her own bits. And
I raised my hand up, please. I will just.
Okay, quickly, sir. Please, quickly.
Thank you. I want to contribute on the issue of medication, free medication that you said about.
Okay.
Because we are even in the Ministry of Health, the advocacy has already getting there. We went for a presentation by Janssen when they presented one of their medication, paliperidone, Invega Sustainer, and they are the new one they get, the Traveta they get now. One woman from either Northeast, either Kenya or just side of Uganda, they came up because the cost of medication is very, very high. Imagine an injection that they are collecting the first start on dose is a 150 milligram.
150,000.
Well, If you want 150 milligram and you start off doses 150 milligram start, then something, and that medication, that one is almost 300,000 naira. You get it? So and they are like, everybody was asking, how could imagine when the person does 150 milligram, the next dose will be 100 milligrams. So, and the person must have been at the level of using Respital, that's a Risperidone brand of Respital, which is very, very expensive. People have been clamoring, and they make it understand that in their country, they used to get, the government used to subsidize. The same thing even in our neighboring country, Ghana. Janssen reported that Janssen, their products, they don't sell to hospitals. The government, they supply to the government. The government will now subsidize so that the patients can afford the price the government will now give it out. So these are the things that can still workable in our country if you would push up the social advocate, so that truly adherence is not getting, we are not getting better virtue of the cost of medication. It's very, and now the cost of medication are very, very high, very, very erratic. Thank you for the opportunity.
Thank you, sir. Dr. Ademola, please.
Yeah, thank you, my able moderator. Good evening, everyone. I just want to say that here in Uganda, we are actually doing a lot. In present, we also have the president of the Mental Health Club. We have a mental health club in our university, and our intention is to ensure that it actually go around the whole university within the country, and we want to move down to the secondary schools and possibly primary schools. So, and one of the advocacy that we are also putting is if the NGOs can also take up mental health the way they've taken up HIV and the rest, because if your mental health is not stable, you are actually not stable, or you are not healthy. And the word in actual sense is that the person has a mental health. And we also collaborate with the Law Society, maybe because I'm also a lawyer. So because we also know that one of the strong defenses you can put forth in anything is that if that person mental health is not stable, whether at the time he or she performed that activity, then you can say that, my Lord, my client was not himself or herself at the time he actually did what you are. So if that it is that somebody can kill and go scot-free because it is proven that at the time he committed that offense, he wasn't really himself, and then the government has a duty to ensure that everybody is mentally stable, so that if you commit an offense, you should be punished for your act. So on that basis, we are actually doing well. And then I want to also thank each and every one of you that this is the second time the mental health is making a presentation, and we hope to do more. Our intention is to ensure that the knowledge is not only for the specialty of the mental health, but for each and every one of us to practice it and to also use it as an individual and as practitioner. So thank you for giving us the platform. We are very grateful, and I'm also grateful to the presenter that she actually take the call when I actually approached her. I'm grateful, and CPAN in general is also very grateful. Thank you. And please let me also thank my brother, pharmacist Christopher. I actually miss you. I miss Jabba as a whole.
Jenny. Thank you.
Thank you very much, sir. Thank you. Our chairman, ma, the floor is yours, ma.
Good evening, everyone. I hope I'm audible.
You have to speak up a bit, ma'am.
Okay, thank you. I'm so glad this evening having listened to this highly educational presentation from our dear Miriam Nakamaya, all the way from Uganda, a clinical psychologist. Ma, we are very, very grateful having you tonight. Thank you so much for making our time to give us this highly educational presentation tonight. And on behalf of all the members of CPAN, we say thank you so much. Okay, I just want to appreciate also the moderator, Dr. Chinwe Ann Effiong, the desk officer too of our dear mental health. Also, I want to throw, throw my salute to indefatigable Dr. Ademola Suleiman, desk officer one. Please, we are grateful for your efforts. As you say, this should be the second or even the third one your specialty group are presenting. Thank you so much. During this call, I cited Dr. Ejiro Foyimbu, our former Deputy President South of PSMA. We are glad to have you on this call tonight. I want to appreciate the newest interim chairman of our Education Committee, Fami former Moma. Thank you so much. Within this 1 week, you've seen what you are doing. More grace to your elbows. I cited Dr. Teresa Pounds earlier. Maybe she have left this call. I thank her too. Okay, so we are grateful. We've started. Next week will be highly robust. Tell your friends. Nobody should miss next week Friday's clinical meeting because we are going to have up to 4 to 5 representatives from the US that are going to speak to us on what we mean by consultant clinical pharmacy. Please, you must be here next week. So we appreciate all of you. Thank you so much and join us next week Friday.
Thank you, Ma. Thank you so much. This has been a very enlightening and educative presentation, which is the whole idea of CPAN's weekly presentation. We started with prayer. We're going to also close with a prayer. I'm calling on pharmacist Hanifa. Please, have I unmuted you?
Hello,
Please
good
go
evening.
ahead.
Okay, thank you very much. Good evening, everyone. I want to thank God for making us to attend, and then we are closing this this meeting. I want to also ask God that whatever we've learned here, may we make it to be an impact. I mean, may God make it to be beneficial to us, and may He make us to be able to impact into our clients and then everybody in general. May God make us practice what we have learned.
Amen.
Thank you, everyone. And
Thank you
God bless
so
you.
much.
Amen.
Yes. Amen. Amen. Thank you, everyone, for attending. Have a beautiful weekend. Good
Thank
night.
you. Bye
Thank
bye.
you.
Bye bye.
Thank you too.
Hear you when you hear me.
Thank you. Good night.